science of turning fiction into fact.
Sometimes kind of real architectural life interferes with intellectual architectural life.
There is no such thing as architecture.
Hello everyone, this is Vikram Prakash recording from yet another week of quarantine, and you are listening to Architecture Talk, hopefully sheltering safely in place wherever you are. We continue our series thinking about architecture in the time of coronavirus, and today I'm talking to Michael Murphy, the founding director of Mass Design Group, Mass Design Collective, really, rather, who is just about probably the very best person to talk about the role of architecture in an epidemic, in a pandemic, because Michael has been working with Mass in the Congo, in Latin America, in many other parts of the world, following doctors and assisting them in building structures that are supportive of epidemics, pandemics, and other medical necessities. So I ask him, what are the lessons that he has drawn, and what can he tell us about architecture and the coronavirus? I hope you enjoy. Here we go. Hi, Michael. Welcome to Architecture Talk. I'm so glad you've taken the time to have this conversation with us.
Thank you so much for having me. Glad to be here.
You seem to be the man for the job, and your firm, Mass Design, seems to be the architectural office perfectly positioned to talk to and respond to the current epidemic we find ourselves in. And I know, you have published a series of op-eds, and you have at least some drawings and outlines about how to set up pop-up clinics on your website. And this seems to be, and you're citing the work that you have done in Africa, sub-Saharan Africa in particular, but in other parts of the world, Haiti and so on, dealing with epidemics of various kinds, working first with Dr. Paul Farmer and others. So seems like if anybody can say what architecture can do in the current crisis, it would be you. So I'm excited to talk to you about this. But let me start somewhere else. How are you doing yourself at home with the, I presume, stay-at-home orders up there in Poughkeepsie as well? How are you adapting, and how have you adapted your home to be more, let's say, healthy from your design principles?
No, thanks for asking. Yeah, I mean, I hope you all are also faring well and are healthy, staying safe and isolated.
I am.
We've my wife and I have moved in, like many others, with my in-laws up in Freeport, Maine. Actually,
okay.
A little bit of space from Boston, and so in that situation, decently, we're doing well, and we have a new child. We welcomed our first son.
Congratulations! Yeah.
Thank you. 12 weeks ago. So, like so many of us, managing childcare is a big question of how of the isolation, and so having some additional hands has been really, really helpful, and a wonderful kind of respite from the busy life that so many of us have in the architectural community of traveling all the time to projects and to new engagements. Cutting down travel and being isolated at home or at my in-laws' house has been a radical shift from my normal schedule of the last 12 years. So, faring, right now healthy and safe, and I certainly appreciative of the opportunity we have to get additional hands on childcare. And your second question about how we're making a house a little bit healthier is definitely something we've been talking about. I mean, part of it is how do we protect our family and our My wife's parents obviously are in the age range of more susceptible to the disease.
Right,
So
yeah.
we've been trying to keep them isolated and also protect ourselves so that we're not co-infecting them. And then we've been putting in air filtration and air movement in the house, and putting the fans on, and kind of getting some air movement in the house, and doing a lot of kind of recommended strategies for protecting food and other things as we bring into the house. So trying to
Are you keeping the windows and doors open as much as you can? Are you
as much as we
providing?
can, yeah, as much as we can, yeah.
Okay.
And one of the things we weren't sure about in the early days of COVID, early days, 3 weeks ago, is how much of it was actually aerosolized. But we are recognizing that more and more of, I think, new studies are showing that aerosolization is part of the contagious pathway of the disease, and so the movement of air turns out to be really quite crucial to managing or coping with or reducing infections of COVID. So air mixing, air movement, cross ventilation, all these things are going to turn out to be, it seems, more and more essential to our strategy for infection control.
Yeah, you emphasize dealing with the air surfaces and water as the key places that design can be effective in the containment of the virus. In particular, I suppose, in the design of clinics. But let's just stay with this topic of, since everybody is in isolation, the media isn't really talking much about, besides 6 feet in public, how you should be thinking about your own home or ventilation or other issues in terms of the design of your own space or your immediate neighborhood, I suppose. I mean, do you have other tips to share with us?
Yeah, well, I mean, it is true. I mean, there's one of these challenging situations is suddenly every space has become a medical space.
Right.
This kind of paradigm shift we're undergoing, where each one of us is now intimately aware of the potential threat of the built environment around us. That, I think, is a radical moment that we're undergoing as a society, and one that has potential significant risks and threats in terms of maybe increased surveillance or increased digital access to information, but also possible new optimistic futures about the way in which we demand more of our built world to perform at a higher caliber and protect us more effectively, not just from snow and rain, but actually protect us from the elements and from the kind of contagious diseases that are around us. This kind of healthy building idea is suddenly in front of everybody's mind. So to your question, like, what else can we do? I think the idea of repurposing spaces that weren't designed to manage infection is something that we can actively do. We can increase aerosolization, sort of airflow. The WHO recommends 12 air changes per hour to reduce infection, at least of tuberculosis. And so I think rules of thumb like that could help us think about our domestic spaces, our restaurants, commercial spaces. I think the other thing is just to learn, like, what are those spaces that are most potentially contagious, and have an increase of our own spatial literacy of what the spaces around us are not protected. And with that kind of increase in spatial literacy, or that visibility that we might have, that, oh, well, that's a space without a window, that's an enclosed room with people in it and there's no air movement, there's lots of surfaces you have to touch to get into it, those are potentially more contaminated spaces that we can try to avoid, like hallways, like lobbies that are sealed off without airflow, some public areas that you can't trust fully, that you can't trust have been protected or decontaminated.
Elevators,
yeah, I think that's exactly right. And I think this kind of mix of simple rules of thumb to both improve the, let's say, air movement in a space. We're all coping with surface awareness, so I think Obviously, cleaning and being protected against surfaces is obviously the second one. But the third is just visibility. I think it's designing for trust, a kind of visibility or visual cues, spatial cues that remind us that spaces around us could be contaminating us, and we can try to adjust towards them and protect ourselves and the community around us. So, in infection control principles, we often talk about three scales of infection control. There's the personal infection control strategies. That's, of course, PPE, I can put a mask on. There's the environmental. I would say that's the building itself, how you might have negative pressure in a room or airflow in a room. And then there's the kind of institutional where, people are institutions are controlling how many people come in or how people are separated or the flow of a larger group of people are all kind of strategies that we can use. And I think right now we're only in the PPE, we're only in the personal protective zone because we're not aware of how the environmental controls around us are being used or optimized. And I think we will slowly move into that space where we can trust more and more of the public realm that's being controlled under certain rules that we agree are working. And that allows us to kind of open up a little bit more.
When I think back at it's not equivalent, but when I think back at the 9/11 in 2001 and kind of the massive transformation of, at least airports, but the general experience of going through a lot of public spaces that event brought about. From there, extrapolating to the coming future, my question is, I'm hearing in your words, and and a lot of us are thinking about this. There is going to be some change in our relationship to thinking about public space, and possibly even some change in let's say rules and zoning and so on and so forth. The question is, I have an ambiguous relationship with the changes that were brought about after 9/11. Do you think, what is your thoughts on, in what ways is this sort of a more healthy or more health conscious or visually, health literate relationship to public space? How can that be a progressive thing, and in what ways do you think it might be more, dangerous or socially constraining?
Yeah, a good question. I too have, spending so much time in airports to feel the burden that we've reconfigured the public realm, which was once a very open space of air travel, into this basically defensive posture, sort of a defensive architecture. And, that's a very reactionary strategy where the built environment was responding to threats in a way that forced everyone to reconfigure the way that they travel or experience air flight. I think you'd see there's a similar argument could be made at least in the design of schools in America in response to the gun violence epidemic that we've been are still a part of. That was the largest, probably the most significant shift in school design has been to protect students against shooters, which is hard for other countries to imagine as a reality, but that is an architectural strategy. I mean, if you look at some of the new schools that are being built, they have to be responding to active shooter situations. And I would say something similar in healthcare. One of the big innovations in healthcare has been the consolidation of strategies around trauma, and trauma being, not just, let's say, car accidents, but shooters and traumatic events or even terrorist events where many people are killed at once. Trauma centers have been configured, as there might be one in every city, but not every hospital is a trauma center. And then they have certain rules and certain protocols, and they have certain flexibilities, and they adapt very quickly to the size of the trauma. And so they've kind of configured both the social, the political, financial, and the human capital together to reconfigure the sort of daily operations of the hospital to accommodate the kind of surge that we're seeing in traumatic events like shootings. So those are all examples of how our systems have changed in response to and reaction to, in this case, very sometimes very American experience of the gun violence epidemic.
Right.
I think when you look back at history, you'll see that so too the built environment has shifted and been shaped by other epidemics, and I think we should expect the same with the pandemic of COVID, that our built environment, the space around us, will radically shift. And get back to, I think, the heart of your question, which was, I think one of the challenging, potential threatening things that we'll see is, and are already seeing abroad, is an increase of the inevitable surveillance infrastructure, the digital surveillance infrastructure that has now kind of proliferated around our lives and is kind of taking hold.
Right.
While that might keep people healthy, it does introduce all sorts of civil liberty questions. When you look at, there's kind of a, as you say, an ambiguous relationship here. When you look at prisons, for example, we're seeing the most radical decarceration happen in prisons, in generations. Yeah. And, so many activists have been arguing for this for years. And to some degree, you might say, well, this is, is one of the, not shining lights, but benefits of this pandemic is, people are being moved out of these horrible environments where they don't need to be, and they're not a threat to society. I mean, and they're being brought home. But what they're also going to experience is what Michelle Alexander calls e-carceration, a kind of digital incarceration where they're surveilled and controlled through other means. So it is something for us to kind of keep an eye on. On the inverse, though, where there's an opportunity for maybe a kind of positive outcome, I think we will see, but I think this paradigm shift of our own, I would even call it a cultural shift of our own understanding of how the built world around us, shapes our daily lives. That awakening, that awareness is happening right now. And it's a moment for us, especially in the architectural and design field, to press hard and ask, how is it helping and hurting? And how can we advance both science, I would say even spatial disciplines, measurement, as well as the advances in our own kind of the work that we're doing in schools, to say, look, architecture shapes our lives every day. How do we guide it towards and understand the way it's shaping us in really positive ways, shaping our communities, shaping our health, and measure that, prove it, show it, advance it, iterate it, test it, and kind of have that dialogue with the public in a much more direct and engaged way. There is this moment that we've all been, I think, looking for, which is especially around the question of climate change, where the built environment, carbon emissions, or 50% of carbon emissions are from the built environment. So we are at the heart of the question of how less carbon emissions in our future, or a climate positive future. Now is the time where we can really push on that. We can press hard and say, this is the time for a rethinking of our public realm, a rethinking of the materials that we use, to actually build a culture of regenerative architecture and fight for that, instead of being so reliant on the kind of industries which have driven us in the past. And I think that moment is in front of us and is an opportunity for us to really take hold of, and I think would align with the cultural shift that we're seeing. We can say not only is there a health of your body, like you can get disease, but there's a health of our community, there's a health of our planet, and all those things are interrelated to keep us healthy.
And we can add to that the economic cost, very clearly demonstrated this time, that it's not only our health and the well-being of the environment and our societies, but also this contributes to overall wealth. I mean, isn't that right?
Absolutely. I mean, access to, or access to fundamental rights is, of course, completely hindered by many of these inequities that these systems are advancing, but certainly the built environment is one of those systems. We talk about tree coverage in neighborhoods, keeping people sick. Certain lower income neighborhoods don't have as much tree canopy, for example. The adjacency to highways where they've been consuming, emissions for decades.
Right.
We're seeing now these moments where cities free of cars are suddenly breathing better. And can we do things like Milan has done to actually close down those roads and give them back to the public? Can we make an argument that restaurants are not safe enough right now, no matter if you're 6 feet apart or have a plexiglass barrier between your banquette, so you have to spill those tables onto the streets and take over the streets? I mean, those discussions I think are really exciting ones that are happening now, and it should give us some hope.
What about the question of the envelope, the building envelope? I mean, a lot of sort of sustainable design seems to focus on that and making them more airtight and non-porous.
Yes,
Would you like to see a fundamental shift in that discussion?
100%. I think the big shift that we need to see, and finally, I think we're talking about this, is the sustainability conversation has been about operational carbon. It's been about how the performance of the building can be as less bad as possible. But the embodied carbon conversation is really, I think, the one that we finally are having and need to have more aggressively, which is, what is the cost of the extraction of these materials and the use of these materials in their cost on the environment just to get them to site? What is the cost of not designing to the climate around us, being reliant on mechanical systems in order for the buildings to breathe? Those fundamental questions, which are not luxuries that every building has around the world, but certainly we expect in the United States. I think we have a lot to learn from the way in which we can build around the world with materials that are local, with climates that are microclimates that they're designed towards and with. The kind of intelligence of a functioning living building has been lost when we're really designing the mechanical system, a building around a mechanical system instead of the inverse, building, designing a building for its specific climate. So I think, yes, that is a shift we will see. I hope we will see buildings that are very actively, not just passively working, but actively breathing in their climate, that are living and seen to live with the kind of use of them. And then also when they finish their useful life, they are decommissioned or deconstructed in productive and sustainable ways as well.
Right. Let's talk a little bit about hospitals. And you talked about how trauma centers and emergency rooms have changed to respond to the gun violence in our country. What is your sense of the medical here in the North America, let's say United States, its preparation, in its architectural design preparation for dealing with epidemics? I know we have piped oxygen, but what about sort of designed systems of the kinds that you are interested in?
Well, I say this with so much respect for the hospital systems and what they're coping with, but I think one thing should be really clear to all of us, that the hospitals in our country are not designed to meet epidemic surge like we're seeing today. They're not designed for that. And that might come as a surprise to the public, but I think as soon as you peel back the layer, it makes a lot of sense. I mean, they're designed with, their financial models are very tight. They have tight margins. They're designed to fill beds. They're designed to, get large specialty services and high reimbursables, and the public health component of them for incredible acute care. There are just certain parts of each hospital that are designed to manage really challenging contagious diseases. So those isolation rooms with negative pressure, there might be one or two on a floor, where we worked with Mount Sinai over the course of the last 3 weeks to help them, and also to study what they were doing as they were actively redesigning their hospital in the middle of the surge in New York City. I mean, it was absolutely amazing to watch how clinicians and the executives of the hospital and the facilities people were just butting up against their inherited infrastructure to try to accommodate to, as best they knew, the infection control guidelines that are actively being written to manage COVID, and do the best they could to protect healthcare workers. But I think if you wanted one measurement that should really shock us and really, I think, reveal how unprepared the built infrastructure of hospitals was to manage this disease, is looking at how sick health workers are getting. 20% are getting infected.
Right.
That number is like staggering, and what it really suggests is that the physical space in which they're working in is not able to be decontaminated fast enough to cope with the kind of patients that are coming in. And we have to really take that seriously and think about that both as architects, but also as active, systems designers. Is what are the quick and dirty things that we can kind of repurpose and reconfigure right now to protect health workers who are in the middle of it on the front lines, and then what does that mean for these buildings, after these surges, and how do they continue to protect the public as they come in there, the variables that they can't control. And it's fascinating to watch, and also I think really pushes us as a design community to say, hey, look, these are not fixed systems. These are like living systems that are changing, and they have to accommodate extreme surge, as well as the inverse of that, the daily quotidian life of a normal public health scenarios. They have to manage both of those things, and we're only prepared for the latter, not the former.
Yeah, so they have to be transformable and adaptable, and switch on a dime to accommodate these kind of situations.
I think that's right. Yeah, and I think that we often in architecture might talk about like utmost flexibility as the strategy, and hospital design in the mid-century dealt a lot with flexibility. But I also think sometimes flexibility, we kind of some of these things have to be really inflexible, actually, which is like the isolation room has to have not just piped oxygen, it has to have negative pressure, forced air outside. It has to have an anteroom for donning and doffing. That's a very fixed infrastructure,
Right.
And that actually is hard to change. It's a question of, can you plug those really kind of rigid systems into a more flexible superstructure, or a more flexible cartilage, if you want to use that word, that can be adapted for surge. And I go back to the trauma hospitals. I think they have figured out a way to do that, converting parking garages into triage centers, for example, looking at the ambulance bays as areas that are isolated from the other ambulance bays that might have normal treatment, so that they kind of control the chaos and the trauma. There's a lot of policies in place that might give us some insight towards a pandemic resilient health infrastructure of the future. So I think there's a lot of learnings there.
Fantastic. Let's travel abroad. Are you engaged with Dr. Farmer or otherwise in COVID preparedness or clinics in abroad, sub-Saharan Africa or elsewhere?
Yeah, we've been, our work began in Rwanda with Partners in Health and continues today. We have over 80 people working in East Africa and some in West Africa. And at the moment are building 7 different projects in a number of different countries. And all of that stuff went on hold, especially the work in Rwanda, where our base is. We have 6 projects under construction there, and those all had to pause during this the spike. And Rwanda's managed COVID in a really aggressive way. I mean, they shut down their borders, they stopped all air travel. I mean, they've really intensely tried to manage it as a small country, with limited resources, but a strong government.
Successfully?
Well, they are managing it from what I understand. We get daily updates. They've been contract tracing. They've been really reducing, if not stopping, almost all travel inside and outside the borders. And they've been very aggressive about social distancing and self-isolation. That being said, essential projects like some of the projects that we're working on will start up again, we believe, in particular because we're building 2 hospitals, one for the capital that's 2 months away from construction completion. So this itself would add almost 200 beds to the capital and be essential, obviously, for this and future surges. The other hospital we're building is in the south of the country and also essential in the kind of broader landscape of that health infrastructure. The projects that we're building in Liberia, though, I think are of interest because those came after Ebola outbreak, the kind of last epidemic
Right.
that we were immersed in, and there were a lot of lessons, I think, from that, from the outbreak of Ebola and how the government of Liberia and Sierra Leone really mobilized to both manage the immediate needs of the outbreak, but also invest in long-term infrastructure that their country needed to stave off the next, surge or the next epidemic. And what Ellen Johnson Sirleaf and others have really fought for during the height of the outbreak are still paying dividends now. And our hospital, the Redemption Hospital, be the kind of central hospital of Monrovia, is under construction, and is continuing through the outbreak because of the essential need of this infrastructure to manage it when the surge really hits the African continent, sub-Saharan Africa.
What are the core design principles that you adopt in hospitals and medical facilities, particularly in Africa or elsewhere, that you think are preparatory for epidemics?
Well, there's a couple of things. I mean, each epidemic teaches us something else about our infection control protocols and whether they're appropriate or have to be amended. What I think TB taught us in Rwanda is that airflow matters significantly, one, and 12 air changes per hour can be achieved without large mechanical ventilation systems. Mm-hmm. And, that conclusion, while maybe obvious and simple, is also kind of radical when we think about U.S. healthcare facilities that right now are completely reliant on mechanical systems.
Right.
In fact, without significant code improvement, it's not possible to build natural ventilation into healthcare buildings in the United States, and that some of that is starting to change. But that was a radical idea, and I think a lot of learnings came from that that I think are applicable now. And one of those is that we need resilient and redundant systems. So we can't fully anticipate the types of outbreaks we might have, and so the more redundant systems we have, if there's mechanical systems, but you also have windows that can open, for example, it allows us some flexibility. And we saw that at Mount Sinai, actually, where the 1920 bed towers are the ones that had windows that could open, but the new bed towers didn't have windows that could open. So they were putting the isolation rooms in the old bed towers because they needed to vent out HEPA filters and into the windows that could open. The idea that hospitals today are built without operable windows is a kind of an amazing and challenging thought. We should think about that.
I know.
The second thing is, I think the second big lesson that I find that applies almost to everything we do, I don't want to say this in an aggressive way, but like hallways are kind of the enemy, we and this maybe many architects have said this before. Maybe Herman Hertzberger said it very directly, but like, how do we design hallways out of our architecture? And there's something really, this is relevant from like the Pruitt-Igoe, in St. Louis to to the medical facilities we see today. I mean, hallways are that in-between space that we like to think lots of interactions happen, but actually what happens is a lot of undefined and undesigned experiences that we are hard to control. And in a hospital setting, what happens is a lot of patients end up waiting in the hallway. There's really bad ventilation. There's a lot of density and potential contamination. There's a lot. It's a much riskier space. It's harder to control in terms of contagion. And so the more that we can keep people out of hallways and design away from hallways, the better. So, in the climates of Central East Africa, we have the ability to have outside hallways. And, that's something that we certainly want to take advantage of. So those are kind of two lessons. And I think the third is then being really clear about the separation of being able to isolate and separate those that are most contagious from those that are the general public. Really being able to differentiate between illness and wellness. And that's happening. You're seeing that now in our medical spaces. Like if you are going for a wellness visit, they're completely moving you now out of the central medical facility into spaces where they're only dealing with patients that have no symptoms. Right. And that kind of clear separation is, I think, something that we're experiencing as well.
Right. You start off many of your presentations, for instance, your TED Talk, with sort of a implicit or explicit critique of architectural education, and perhaps its values.
Is that how it's read? Oh.
Well, I'm in the education business, so maybe that's how I read it. But I am interested in your thoughts on looking ahead. If you've talked about taking advantage of pressing the kind of cases that we have in a sense been making about the necessity of good public space, of passive design and so on, and pressing them into the public realm and making our case. What are the kinds of things, what are your thoughts on architectural, what were the sort of things you'd like to see happening better in architectural education after the present crisis?
Yeah, I mean, I want to state for the record that I have great respect for the architectural education, both the pedagogy as well as the process of how we think about the built environment in its myriad different ways. And the kind of what is so exciting and challenging about the education of architects is how we straddle both the science of buildings as well as the humanism of the art form, and that the one without the other is impossible. We need both of them. We need kind of the practical, the pragmatic, as well as the aspirational and the optimistic and the utopian. These things all together form, I think, our built world around us. And only in the school do we get access to all of that complexity and nuance and challenge. And I would also say real work ethic, a kind of commitment to fighting and pushing yourself and challenging yourself. And all those things are embedded within the pedagogy of architecture, which I think are really essential and important, and have also given me the hope that I have that we can do something. And my implicit critique is not so much that we failed as educators, but that our discipline has to some degree failed to be ready for the kind of the crises around us, and we have at some level been forced into a corner, but also I think given away agency that we, I think, hold as the fiduciary stewards of a public good. And it is a real value that we provide to the public, and we should be advancing that, advocating for it, telling the stories about how the built environment around us can improve our lives, but also can injure us. There's just a real essential service and essential human right that we provide. And I think we have more to do in the academy to make that relevance more forward in the minds of the professionals that we're training. And, I think that's an opportunity I think we can see, and I think we're at that moment right now, an existential moment. What happens when what happened in 2008 with the financial collapse is when I was coming through school is the same thing that students are going to be dealing with now, which is the complete collapse of the architectural business model. I mean, we are going to see probably, a hemorrhaging of staff. We're seeing some of that already.
Right.
Projects drying up all over the place. Infrastructure and architecture really becoming an industry of thriving economy, not an industry of struggling economic situations. And so architects are kind of the first to go. They're like the canary in the coal mine for like the economic
Right.
collapse.
Yeah.
And I think that should also wake us up to a question of not just why we practice, but how we practice.
Yeah.
And how we practice as a discipline it's not just about garnering a commission. It's about providing this crucial service to the public. And so should we be paid a percentage of construction cost, or should we be paid by providing that because we provide that service to the public? Is there a way that we could reconfigure the way that we practice our business models so that we're insulated from the kind of whims of the market as it kind of thrashes us around as a discipline? Could we be insulated by that by working for things that are outside of the market, or work before a market emerges? These are the kind of questions that we've been asking, and to some degree because we've been forced to ask them by working in settings that were really, not markets for architects when we started working in them. And we set up our firm as a nonprofit organization, and what that really means is that we are a mix of philanthropy and grants as well as revenue. We still charge service fees, but we are able to garner grants and philanthropy in order to do the work necessary that can't pay for design yet, or is before the market, in order to catalyze and incubate design work way upstream and make the case for why architecture is valuable in like a community, or for a certain nonprofit organization, or just in rethinking the space around us. And what that has left us with is a certain insulation from the market challenges we're facing now. Not fully insulated, but some insulation that's going to keep us, I think, working through this crisis.
No, you've become. You should be experiencing a boom. One would imagine, like Amazon is. Like suddenly, this becomes a critical service. So what I would want to take this to is, you put in very critical terms there. Giving away agency. I mean, it seems to me that some of this giving away of agency occurred when we sloughed off urban design and planning and other disciplines from architecture. When I think for all its ills in the 50s and 60s, when in a more sort of a modernist time, the public good was more centrally the business of the architect. Was it not? I mean, it seems to me perhaps we have to rethink this sloughing off into disciplines.
Yeah, I couldn't agree more. I mean, there was, modernism had an incredible social project. Of course, we see the public good in the era of sanitation, the sanitation era in the 1870s and 80s, which also
When it began,
it began and was all about how does architecture improve the lives of the public. Everything from William Morris to Frederick Law Olmsted to Florence Nightingale, who, not an architect, also may have had the most impact on the hospital infrastructure of the 19th century. In these, look at Isambard Brunel, architect, engineer, designer, bridge builder, tunnel builder. I mean, this guy was so amazing, and he changed the way that the built infrastructure around us was performing, but also accountable. And there's so many lessons of the history of our discipline that say that these things are intertwined, that the profession of architecture and the public service and our health are all interrelated, and they can't be separated. We only really there has always been a strand that's tried to separate them, I don't want to name names, but we could talk about who they are. But was a significant disciplinary shift in the late 70s, where theory really embraced the idea that separation was necessary, and to some degree fetishized that separation, to theorize it, talk about it, and create a kind of disciplinary hemorrhage where we could pretend like architecture could be simply discussed only outside of all of its other social and political conditions.
Right.
And I think that moment was a really dangerous experiment. Dangerous might be a little extreme word, but has had long-term downstream effects, not only in polarizing who we serve, i.e., that architects are really in service of the elite and the rich that can pay for them only.
Mm-hmm.
And it's a kind of boutique product in which we show off a certain status, but also kind of cleaving off all of the disciplinary knowledge, intelligence, work, and advocacy for the public good as not real architecture.
Right.
And that the idea, that there's the separation between like real architecture and not real architecture that we still struggle with in school today, I think is something that has to end, because that theoretical project has been confusing our discipline, I think, for 40 years. And thank gosh, thankfully, I should say, that's starting to change as a demand from the students, but also as a demand from faculty that we prove our relevance and value and service about what we understand architecture to be and what its value is in the world.
Mm-hmm. Yeah, no, I couldn't agree with you more. I mean, completely. So thank you for that. As we move towards the end here, I just wanted to sort of switch scales a little bit. You've mentioned how certain materials are, of course, better than others, and how cottons and wood is much better than steel and plastics we are finding with respect to this particular virus. And you also mentioned that the various scales at which prevention works, and one of them, of course, is the personal. You mentioned, we all know about face masks now, which are kicking in. I mean, it seems to me, from the one side, it's the public realm and the city and everything else that is also a topic for architecture, but also at the other end of the scale, clothing, and if you want, fashion is also a topic of architecture. I mean, architecture begins the moment we are dealing with space right outside the body. Does it not?
Yeah, I think I didn't think about it that way, but you're right. The face mask is a kind of spatial, is a sort of
it's mini architecture, isn't it?
Yeah. It's a hint or a tell that the space around us is something that's jeopardizing us. I think, well, yes, I agree with you. Architecture is everywhere, and there is architecture in everything. But I also want, for the purpose of having the same debate and also building a kind of spatial vocabulary with the public, which is, I think, something else we need to do in the academy, is help differentiate which scale we're talking about. Use the word scale. I think that's the right word. Mm-hmm. And I go back to these 4 scales, and we could introduce more. But there's the scale of the body, mm-hmm. the face mask, the room. There's the scale of the neighborhood, which is about, maybe the planting of trees or the management of streets, the zoning of buildings, heights, and, access to, water. There's the scale of, you could say the scale of the city and the scale of the nation. And then there's the scale of the planet. Right. And there's, and obviously decisions I make about one building affects many of those scales all at the same time. If I choose, to import steel from China and certain plastics or polycarbonates, or if I, who we're serving in what community and how it affects the buildings around it, all of those decisions are there's a heterodoxy about how they all interconnect. And I think one of the challenges we have is we have to clarify which scale we're talking about to be very specific about each one and then try to address each one so that we don't forget the other ones. And a building obviously is interspersed with all of those scales, and it's challenging to get the public to speak on all of those scales. We can only speak sometimes on whether I like it or not like it. Well, that's not effective critical
Right,
engagement.
right.
Oh, I like the way it looks. I don't like the way it looks. It's not. That's that maybe is one scale of discussion, but there's this entire other scale about the materiality, about the labor that was used, about its performance, about its functionality, and about its beauty and dignity. It's about its planetary impact. And once we build, I think, a richer spatial vocabulary with the public, that's also part of recreating this agency and rebuilding that trust, is we can have that discussion on multiple scales. And that would increase our dialogue about how buildings affect us. It would increase the value that we assign to certain buildings. It would change business models if we could do so, because you'd be applying value and financial value to certain thresholds of those meeting of those scales, and we'd be more integrated as that public servant that we really are into the daily life of the community.
Well, here's hoping some new ways will emerge for us to better integrate into the public life of the community and the city and the countryside and the nation and the planet, really. Mm-hmm. Michael, thanks for taking the time. I really enjoyed this conversation.
I did too. Thank you so much.
Thank you for listening to Architecture Talk. This is your producer, Amelia Jarvinen. We hope you enjoyed the conversation, and if you did, please subscribe and rate us on iTunes or Spotify. We would also love to hear from you if you have any suggestions on new topics or guests. You can always reach out to us on our website, Facebook, or Instagram. Thank you again, and until next time, this is Architecture Talk.